Okay, good afternoon, everyone. Once again, welcome to today's webinar. Before we proceed to the webinar, I'll be giving a brief introduction about Yetenaweg and what we do as an organization. So, Yetenaweg is a network of volunteers that's registered in the US as a non-profit organization, and it's entirely run as a non-profit by volunteer members. As of now, it has under 50 active volunteer members across 5 different countries and counting more. So the main areas of Yetenaweg function is divided into 4 areas. So we work on health promotion, community engagement, mentorship and skills sharing, and finally medical education. So as part of the health promotion area, we continuously contribute to health promotion works and awareness creation programs, including the clubhouse live discussions, health articles, free online webinars, and direct social media engagements, as well as YouTube videos you'll find on various social media platforms. So this is a part of the health promotion works. So you can see the Yetena website on the screen. This is our podcasts. The second arm of Yetena is mentorship. So as part of the mentorship program, we engage with senior and expert physicians and other healthcare professionals and pair them with young and aspiring medical students so that there will be a transfer of experience and knowledge. The third is the research project, ROHA research, Yetena in collaboration with ROHA. So this research fellowship prepares grants for upcoming researchers who compete, and finally, if they win, they will be given a grant to conduct their researches. So this is the Yetena Health Article Writing Competition. This is an initiative prepared to, these sessions are a sort of podcast, and we have disability inclusion in healthcare and cancer advocacy program. Here you can see the posters. So coming to the main arm of Yetena, one of the very strong departments is continuous medical education, which actually prepared today's webinar. So we prepared different webinars on important health topics with expert physicians. So this is the last health and art exhibition prepared by Yetena. Today we ask the section if you have any question, and once the presentation is done, we'll be proceeding to the Q&A section. There will be a brief discussion. The expert speaker today will be entertaining questions from you, our audiences. After that, we'll be posting the quiz link in which you have to get 50% or more to get certified. Make sure you answer the questions and attend most of the webinar to be certified. So the certificate webinar. So enjoy your stay with us. I'll be giving the floor to Dr. Samon. Thank you.
All right, thank you, Dr. Khalid. So to introduce our guest speaker today, today's session will be delivered to us by the notable Dr. Nebiyu Getachew, who's a distinguished graduate from Addis Ababa University's medical program, who joined the staff as a physician upon completion of his studies. He has since specialized in internal medicine and nephrology, and he's currently serving in both the renal unit and the Department of Internal Medicine. So I'd love to give the floor to Dr. Nebiyu. Please proceed.
Good afternoon. Thank you, Doctor, for your kind word. So today's Yetena presentation will be on updates on approach and management of a glomerular disease. Generally, even though there are a lot of updates, including the 2021 guideline and the 2024 Lupus Nephritis guideline, I want to focus and give emphasis on the basics of glomerular disease approach to patients, and then more emphasis to give on urine analysis. So my outline of discussion will be to discuss the epidemiology and challenges in the developing countries, and what is different about GN regarding GN in low and middle income countries, and to discuss a few points about clinical features and what is new in the workup and management of glomerular disease. So generally, GN is not much diagnosed in our setup for a lot of reasons, being absence of this important serology tests as one of important limiting factor, late presentation of patients, so that patients usually present only in the stage, so where the workup will not much revealing, so because it's already fibrous later stage, so more the focus will be given on supportive care. So this is a study done by Dr. Abel regarding patients. He tried to review biopsy result of 30 patients, among which 60 of them were male, with a mean age of 34. As you see, most of the glomerular diseases are in the young age group, and we will see later on CKD of unknown etiology also being described in African setup literatures and also be seen in studies from Ethiopia. So one of the studies in Zewditu Memorial Hospital, CK and retrospective study, a 5-year on patients on hemodialysis. One of the etiologies is CKD of unknown etiology, in stage from unknown etiology. So likely this etiology, as in any other African setup, might be possibly a missed glomerular disease, because patients present late to the health facilities where they are not getting the right treatment. So in this study, the biopsy results showed like most of the biopsy was done for patients who present with a nephrotic clinical picture, and among this, FSGS, focal segmental glomerular sclerosis, account for the majority of the cases, followed by membranous nephropathy. And then 4 out of 5 patients with membranous nephropathy has evidence of anti-PLAR to antibodies, where we will discuss later on in this in our sessions also the role of PLAR antibodies, is phospholipase to receptor antibodies in the diagnosis of membranous nephropathy. And other etiologies are minimal chain disease, membranoproliferative disease, IgA nephropathy, and vasculitis like post-immune glomerulonephritis, where among the described pathologies in this biopsy-proven study. So if you see other studies from St. Paul, which was done a retrospective study from 2016 to 2020 in patients with lupus nephritis, biopsy was done in some of the patients, and in different lupus nephritis class were also described in that study, and the study outcomes with immunosuppressive treatment like cyclophosphamide and penicillin showed a significant treatment response. So most of patients, another study again done by Saifa for his internal medicine specialty program training, tried to revise the patients with clinically diagnosed lupus nephritis, and some of them having a biopsy. Lupus nephritis has also shown a good treatment response with immunosuppressive therapy, even though some of the patients has progressed to end-stage renal disease, and some of them died because of treatment-related complications, most importantly, infection-related complications. So it's to mean that most of what has been described is from hospital data, which are limited data. Okay, there is also unpublished recently studied data regarding PSGN, what are etiologies, okay, and outcomes of patients who present with rapidly progressive glomerulonephritis. But the etiology, again, in these patients with rapidly glomerulonephritis, in most of them is unknown. One of the important limitations is because of the cost, which made unable to do accurate workup and lack of a biopsy. Okay, so but in terms of the variety of pathology, almost what has been described in the literature, we see different forms of pathology description. like membranoproliferative GN, okay, immune-mediated, C3 GN, okay, dense deposit disease are also seen. It is a tip of the biopsy result description, what has been described in our setup. So there are a lot of challenges, not only in Ethiopia, but also in other sub-Saharan African countries and Asian countries, okay? This is to show that the challenges, okay, so most of glomerular diseases are focal segmental glomerulosclerosis, and to diagnose this, it needs biopsy, okay? And among the secondary causes, lupus nephritis is commonly described in low and middle income countries. Similarly, what has been described from St. Paul and Columbus Hospital, a description regarding lupus nephritis. And most of the time, this lupus nephritis is also being encountered in our practice. So the issues what is a limitation behind the diagnosis of glomerular disease? One is regarding cost, okay? Cost, because most of the biopsy reports are done abroad where they are too expensive for the patients, and there's a extreme fear from patient side because patients have a fear that by taking a biopsy, they will think that it will incur a problem to their kidneys. But we need to push our patients for a biopsy, because unless we do biopsy and know the exact etiology of the glomerular disease, patient will progress to end-stage renal disease and lose his kidneys or her kidneys at the end of the day. So it's important to give emphasis in order to, about regarding kidney biopsy, in order to settle and reach a diagnosis, okay? It's very important. Then the other is lack of infrastructures like electron microscopy. So nowadays, immunofluorescence are done at some private setups. Okay, there is some improvement because there is now renal pathology is available in the country, and he's doing his best by giving his service to our patients. So, but we need to have a lot of more nephropathology services and immunofluorescence and electron microscope studies, so that to improve the care of our patients. And also high burden of communicable disease, make a challenge in terms of treatment of this glomerular disease, and the availability and cost of this immunosuppressive therapies, okay? Because mostly these immunosuppressive therapies are quite expensive, and especially for those patients who get the service out of pocket, and there is also interruption of the continuity of these services, okay? So there is, yes, clear lack of data and registers regarding glomerular disease in our setup. This is not only a limitation in our setup in most of our low and middle income countries, but for sure we need to improve this data, and we need to show what looks like the burden of the problem, and we need to address that, okay? And as it has been stated, glomerular disease accounts quite a number of patients. And among patients with end-stage renal disease, 20-25% is due to glomerular disease. Especially, this is a commonest etiology in sub-Saharan African countries. Okay, it's next to diabetes mellitus. It's a most common cause for renal failure. Okay, and if you look at this study, what looks like a prevalence of end-stage renal disease of unknown etiology in African setup, it's quite very high. So similarly, in Ethiopian study, one study shows around 8% end-stage renal disease on hemodialysis of unknown etiology. So in this study, what is the etiologies? What are the reasons behind unknown etiology has been described. One, late presentation of the patient. So patient present with bilateral shrunken kidneys where it's difficult to do renal biopsy, the risk outweighs the benefit, and patients usually present with uremic emergency. That makes it difficult. So most of the care will focus on optimization of the end-stage renal disease care, and preparing for subsequent transplant. So there are many theories in other African setups, not only glomerular disease, interstitial diseases from nephrotoxic agent, from herbal medicines, from pesticide, and others are culprit reasons. Most patients with glomerular disease will not present the classic manifestation that we have been taught in our medical schools, where patients will have body swelling, proteinuria, and acute rise in creatinine. That is not a common presentation. So most of the patients will have, some of them may have an active hematuria and proteinuria with no significant body swelling, but progressively resulting in end-stage renal disease. Some of them have a like courses where episodes of increment in creatinine, again, being stable in some other time, so having a flare at other points. So the typical course, that rapidly progressive glomerular disease, might not happen in all of patients, okay? Or generally in most of patients, that's not the case. So having that asymptomatic presentation, and patients also may see their urine having a protein, they may see they have frozen urine, but they will think that it will increase as time goes on, and later on progressively ends up in renal failure. So I have encountered one patient a week back. So what happened? She noticed on and off type of frozen urine, usually in the morning. So she was looking at that for more than 2 months, but she was thinking that it will get improved, and her husband also encouraged her that it is fine, it's going to be okay. But later on, she insisted to seek a medical evaluation, and when she came, when I do 24-hour protein, it was like more than 1 gram, and I did a serology test because she has also a new onset of hypertension, hematuria, so the creatinine is okay, and a serology result turned out to be HANA positive with high titer, anti-DNA positive. So even though as a manifestation of lupus nephritis, like the extrarenal manifestation has not been yet seen, but such kind of asymptomatic, which looks like subtle manifestation, also be the main reason. That's why patients will present late to a medical service, and at some point in time they may have body swelling, which as a result they think that they are okay. So, or they have seek medical service where they're reassured and given a diuretics, then the body swelling has disappeared. So which may require other intervention, but progressively the patient may end up in stage renal disease of that. That's what would be the culprit reasons for an unknown etiology. Yes, it should be well studied and described what is the cause. Okay, then for sure, or with a confidence, we can say this is the etiology or a reason behind the development of the renal failure. And yes, in somewhere in the Far East and the other Asian countries and Latin America, there are causes of CKD of unknown etiologies, where most of them are related to interstitial nephritis. Okay, so it's important to give a due attention for subtle presentations also, especially not to overlook proteinuria and hematuria, where these are telltale signs which needs further workup and subsequent might even require biopsy to know the underlying etiology, so that to address the underlying pathology. So what are the pathophysiology mechanisms behind these glomerular diseases? Okay, there are different pathophysiological mechanisms and different approach generally for patients with a glomerular disease. Okay, so there are a clinical approach. Okay, clinical approach, usually patients being described as having isolated hematuria, hematuria plus proteinuria, isolated non-nephrotic range proteinuria, nephrotic range proteinuria. Okay, these are clinical classification based on pathophysiology mechanisms. Also, can be approached in a different way. Okay, one is inflammatory and non-inflammatory immune injuries. Okay, so inflammatory injuries usually they will have an active urine sediment having hematuria, RBC castus, dysmorphic RBCs, plus or minus proteinuria. So these patients might be accompanied with a decreased in GFR. Okay, so usually this happens when there is an inflammation in the subendothelial, okay, in mesengial, where the mesengial cells are affected. Okay, when you say active urine sediment, we mean one is hematuria. So hematuria, it can be tract-related hematuria or a glomerular origin hematuria. We say glomerular hematuria when we see an RBC cast for more than 40% of the field that we saw with a dysmorphic RBC or proteinuria accomplished with proteinuria. But some of them are immune-mediated injuries where there is no inflammatory, okay, non-inflammatory. These entities like membranous disease, okay, there might be deposition of antibodies, okay, so there might be immune-related injuries, but these usually target the podocytes, okay, the ultra-structural and functional damage, okay, they may result proteinuria, but they may not have hematuria or this what we call the active urine sediment, okay? So, so depending on where, which part of the glomerulus is affected, the patient will have a different kind of manifestation, be it in a form of hematuria or hematuria plus proteinuria or isolated proteinuria. Okay, so so what are the clinical features of someone having a glomerular disease? Okay, as we said, it might vary from having a symptomatic, okay, to may have someone hematuria, edema, hypertension, and proteinuria, which might even peak when someone comes for a routine medical assessment. Okay, but sometimes this might be having an acute fulminant kind of course. Okay, a patient may have rapid increment in creatinine. Okay, result with having an acute kidney injury, and possibly they may have extrarenal manifestation. Some of the systemic diseases like lupus, they may have an active disease from the lupus like joint pain, skin rash, okay, polyserositis, and they may have concomitantly renal manifestation. Okay, so patients may have extrarenal manifestation. Patients may present with isolated renal manifestation. But generally asymptomatic urinary abnormalities are much more common, which are less specific. So we need to give due attention for this asymptomatic, which usually been treated like urinary tract infection. Okay, so again, one study which was done in Zauditu Memorial Study Hospital about the cause of CKD for among patients whom was follow-up for a chronic illness. And in this study, most of the chronic illness are DM, diabetes, and hypertension, and some are cardiovascular disease. And when they see the association between this chronic illness and then the renal disease, so some of the patients, they were told to have urinary tract infection at some point in their lifetime. Okay, so what is that urinary tract infection? Is it really a urinary tract infection? Or are we missing a glomerular disease by saying it is a urinary tract infection? Okay, so usually we see patients with having asymptomatic bacteria being treated as a case of urinary tract infection. Sometimes patients have interstitial nephritis because they have a pyuria being treated as urinary tract infection. But these patients usually will not have this low urinary tract infection manifestations like the frequency, the dysuria. Okay, so having this pyuria is not equivalent with a urinary tract infection, especially in the face of having no symptom. Okay, so generally to begin with, there is no need to treat someone who is asymptomatic, okay, unless a patient is pregnant or in the first few months of renal transplant, or there's a plan for a urologic intervention. Okay, so when someone having a symptomatic pyuria, especially having concomitantly proteinuria and hematuria, we need to think about is it a glomerular disease? Okay, because the treatment and the outcome is quite a different. Okay, so sometimes they say they will be treated for recurrent UTIs, and the patient also say have a urinary tract infection. Okay, take it like someone having a chronic disease, like they always have that. Okay, not even like recurrent UTI. Okay, so this might be missed gene. Okay, and Membranous GN or interstitial nephritis or some of the chronic pyelonephritis cause. Okay, so when we say especially proteinuria combined with hematuria, even though being the creatinine is normal, we need to have and to look for a possible cause of GN. So we need to work up for glomerular disease. Yes, for sure, we need to rule out tract-related issues generally before going into aggressive treatment as a glomerular disease. But we need at least to have a workup. Okay, so most of dramatic symptomatic presentation that we say is the rapid progressive glomerular disease-like manifestation, or the full-blown nephrotic presentation with hypoalbuminemia, body swelling, proteinuria, and dyslipidemia are not the commonest presentation for as a clinical feature of a glomerular disease. Okay, so what is a clinical feature of hematuria? We say glomerular hematuria when we have an RBC cast, okay, or if we have a dysmorphic RBC on the urinalysis, okay, and if someone has a proteinuria accompanied with hematuria, especially when the proteinuria is above 500 milligram to 1 gram, think of it as a glomerular origin. Okay, so it's only when it is isolated hematuria without proteinuria or less proteinuria, especially age above 40, we think about structural or tract related. Okay, but when we have hematuria, okay, especially persistent one, we need to see the 24-hour urine protein, so that we need to check whether it's accompanied by a proteinuria, where it will tell us, or it can be a telltale sign as the origin is a glomerular origin. Okay, so that we can prevent the progression of a disease, and then especially which is an stage renal disease, which has a clinical implication of cardiovascular and renal replacement therapy. Okay, so isolated, there are some causes of isolated glomerular hematuria without proteinuria. Okay, someone having a glomerular origin hematuria that we detect by RBC cast or a dysmorphic RBC. So especially mild form of IgA nephropathy. By the way, IgA nephropathy is the most common cause of GN worldwide. Okay, especially in the Far East is more common. Okay, and the other causes are important. Some familial diseases like thin basement membrane disease nephropathies are a cause of isolated glomerular origin hematuria. But as we said, careful work for extrarenal etiologies should be undertaken, including abdominal ultrasound, cystoscopy, and in some groups for a sickle cell trait should be looked into. The other important thing is pyuria. When you say pyuria, as we said, it's not necessarily by urinary tract infection or cystitis. Okay, it can be due to post-streptococcal GN, lupus nephritis, membranous proliferative GN, interstitial nephritis. So when we see clinical feature of having pyuria, especially in the phases where asymptomatic, were accompanied by increment in creatinine, rapid progression. So it's less likely to be a urinary tract origin. Okay, we see sometimes having pyuria. Okay, severe flank pain where a patient is quite okay except the flank pain, and sometimes accompanied by the fact that now they are vomiting due to this capsular distension, okay, and irritation due to the intense inflammation in the interstitial nephritis. So when usually they have bilateral of this manifestation with raised creatinine, that think twice. So it's not, this pyuria is not necessarily this pyelonephritis or this cystitis. Okay, this is likely to be possibly interstitial disease. Okay, because this rapid in creatinine for someone who is quite stable is not to be explained by this only structural problems. Okay, so always think GN as one cause of pyuria, especially where the sterile pyurias. Okay. So the other presentation of a glomerular disease is non-nephrotic proteinuria. Okay, we say non-nephrotic is less than 3.5. So we usually do 24-hour urine protein. Okay, so this non-nephrotic proteinuria can be a transient one. Okay, it can be due to orthostatic or overflow proteinuria. Non-nephrotic range proteinuria usually less than 1 grams, where not accompanied by hypertension, not having hematuria, not having raising creatinine. We can see it by giving a time, because this might be a transient proteinuria. Okay, but if they have hypertension or hematuria or raised in creatinine, we need to be meticulous in workup for this non-nephrotic range proteinuria. So what looks like the evaluation of patient with J? So we need to take a history. Okay, history is very important. Okay, patients will tell you they may have a body swelling which started recently. Okay, so patients may have the body swelling even menses. Okay, so especially they may tell you like 4 or 5 months. Then even having this long duration of 4 or 5 months, okay, by definition more than if you think a proteinuria or raised creatinine more than 3 months is chronic disease. Yes, it's a chronic disease, but don't lose hope, or it's not necessarily CKD is not necessarily or equivalent to irreversibility. Okay, so yes, having a protracted course of proteinuria, the chance of recovery, progression for end-stage renal disease, and its implication on cardiovascular morbidity and mortality is high. Yes, but it does not mean that it's irreversible. So if the patient is having an active urine sediment, even though the duration is somehow protracted, we need to work out for the underlying etiology, because with aggressive treatment, this can be progression can be reduced. Okay, and quite reasonably for years, the reversibilities also can be achieved. So most of our patients come far from rural areas. Okay, so they may come with a protracted course of this manifestation of active urine sediment, body swelling, nephrotic or subnephrotic range proteinurias with raised creatinine. If their kidney size is preserved, we need to be more aggressive workup and consider timely referral for a nephrologist for subsequent management. Okay, so on history, the most important thing is to ask the onset of the disease, like the manifestation, like the body swelling, when they start to look this urine color change, like the color color change, this frozen urine. Okay, when they start to have the extrarenal manifestations. Okay, and also it's important, especially in elderly age group, to look into underlying etiologies like malignancies. Some malignancies, their manifestation might be a nephrotic presentation. Okay, nephrotic presentation like a membranous nephropathy. Okay, might present with might be a cause from the underlying malignancy. So some malignancies from colonic malignancies, okay, ovarian malignancies their presentation might be a nephrotic manifestation. So we need to when someone elderly present with a nephrotic syndrome, looking into malignancy is one of the workup of a patient with nephrotic presentation. Okay, so the other is recurrent sinusitis, okay, respiratory tract infections, okay, new onsets, airway disease, okay, like asthma. So this might be vasculitis associated, okay. So hemoptysis, renal pulmonary manifestations, okay. Someone who present with was a non-resolving pneumonia, okay. Okay, we need to approach as a non-resolving pneumonia. And one of the cause for non-resolving pneumonias is renal pulmonary syndromes, okay, vasculitis like this post-immune vasculitis, anti-GBM disease, okay, might be the reason. So when you see presentation like ND and also vasculitis, we need renal manifestation. We need to consider renal pulmonary manifestations. Okay, so the history should be so not only limited to the their complaint in terms of the urine color change, decrement, body swelling, but also a systemic manifestation should be looked into so that to reach underlying etiologies. Someone who has a recent throat infection, skin infections, okay, it's important, okay, and also patients with having a chronic infections like osteomyelitis, abscess, may have infection-related glomerular disease. So this also be detected by the history. So, and history is also very important to reach some of the disease entities like myeloma-related kidney complaints, even in short of biopsy, by having their multiple myeloma, we can consider that their renal manifestation is due to a systemic manifestation from their multiple myeloma or generally paraprotein related disease. So it's important to ask this detailed history of the other important history is because patients are going to receive immunosuppressive therapy. Okay, it's important to look into risk of infections of TB. Okay, TB is one of the infections which get treatment get more complicated because the immunosuppressive therapy will result in a flare of tuberculosis. So there are now plans to start treatment for the latent TBI for whom who's going to start immunosuppressive therapy elsewhere in low-middle countries like India. They give treatment for latent TB while they receive the immunosuppressive therapies. Okay. The other is to look in physical examination, looking into their vital sign blood pressures. Okay. And also it's very important to look the cutaneous manifestation of a systemic disease like vasculitis, lupus. Okay, it's very important, and also clinical manifestations. So recently that I encountered one patient whose diabetes was poorly controlled. She developed an ulcer over her lower extremity, bilateral lower extremity. So it's around the calf area. So it's not a typical site for a peripheral arterial disease, a venous ulcer. She came from rural areas where the families were giving a wound care at home for 3 months. Okay, and when she came, her creatinine was like 1.9, and I know she has poorly controlled DEM with high A1C. But when you work up, because the site was atypical, her ANA was turned out to be positive. So, in general, in terms of management of the underlying her kidney problem, will shift from not only as the cause for her renal problem, diabetic kidney disease, but other disease entities like lupus nephritis. So ideally, we need to do biopsy, make sure that it's not related to the complication from DEM, and then to make sure that the type of the class of lupus nephritis. So, we need to look into this settlement, which looks like subtle, but will tell us, because skin manifestations are very important to as entry point. So we need to look also systemic manifestations, as usually the polyserocytes are being treated TB. It's always good to consider TB as important etiology, but in young females when having a polyserocytes combined with raised creatinine, we need to think about lupus also, okay? So physical examination, as I said, is very important, and in terms of also picking etiologies like some of IgA related vasculitis, HSP, as this dependent area vasculitis. So it's important to look at physical examination. So the investigations, always we need to exclude non-glomerular disease, like if someone has diabetes related to complications with diabetes, okay, we need to work up, okay, because the treatment sometimes like someone who has infection-related GN, okay, the treatment is quite the opposite because immunosuppressive therapy will get worse of this infection-related GN. So it's important to look for the systemic cause, okay. We need to see the trend of the renal function test. We need to work up for the underlying etiologies, okay. We need to ask a family history. Some of the diseases are familial, okay. We need to see the correlation, the time that the synpharyngitic type of IgA from the postpharyngitic type of post-streptococcal nephritis, and we need to also look at drugs. Sometimes drugs can be the causes for this glomerular origin proteinuria. Okay, some of the treatment is like the analgesics, okay, NSAIDs as related to minimal change disease. Okay, some of the treatment is recently, and now the developing treatment is malignancy related treatment. So the tyrosine kinase inhibitors, okay, which were our patients received, be it for their thyroid, say CMA or other malignancies. One of the side effects from the treatment is proteinuria. Okay, so it's always to look into their drug history. Okay, so we need to ask details, and as we said, malignancies also can be the reasons. Okay, so when you see xanthelasma, this palpable purpura, okay, this will help us also in the assisting our diagnosis of glomerular disease, with some of them telling us a specific diagnosis. Okay, so what looks like the workup for patients with glomerular disease? So so 24-hour urine probe. The first, always the entry is urine analysis. Okay, the liquid pathology. So we always not to underestimate urine analysis. Okay, and always not related to the urinary tract infection. Okay? So proteinuria with hematuria, do please 24-hour urine protein. Okay, and for patients with nephrotic presentation, it's important to do 24-hour proteins and others also, because it helps us in terms of follow-up for the treatment also, because the responses are also being followed by the response for a 24-hour urine protein. Nowadays, complement levels are available in town, so the turnaround time is short, like a previous days, which requires 2 weeks. Okay, low complement levels, low C3C4, mostly related with lupus nephritis, and then some of infection related genes like endocarditis. Okay, low C3s has multiple causes, being most commonly post-focal gene, but if it is persistent, we need to think of cyst-related membrane proliferative gene. Okay, IgA may have a normal complement level. Post-immune may have a normal complement level. Most of nephrotic presentations or patients with clinical nephrotic presentations may have a normal complement level. So the other is ANA. ANA, qualitative and quantitative. ANA, preferably quantitative, is better in terms of sensitivity. So ANA titer is another important thing. ANCA, especially the ELISA, PANCA, and CANCA should be looked into for someone who presents with RPG, but other presentations also possible. PELE, phospholipase receptor for antibodies also should be looked for causes like membranous nephropathy. Okay, someone with membranous nephropathy, if the titer of tail is high, and just by looking at his titer with a clinical implication like the degree of proteinuria, treatment can be decided. Okay, so don't forget also to look, especially SPEP with free light chain. Okay, SPEP with free light chain, elderly people presenting with anemia, okay, plus or minus hypercalcemia, okay, dipstick urine negative in 24 hours, urine proteinuria high. So this might be paraproteinemias. Okay, so the spectrum is quite different from monoclonal gammopathy of renal significance to multiple myeloma with a spectrum. Okay, so we need also to look for infection. Okay, infection-related GN are one of the causes. Okay, hepatitis B related. Okay, C. Okay, patients with retroviral infections. So, and blood culture also should be done, especially when we think of infection-related GN. Okay, and parasitic infections like filariasis also can be a cause. Okay, leishmania is also a non-cause. Schistosomiasis is also another non-cause of infection-related GN. Okay, so and in some of the recent entities, genetic evaluation might be required to know the exact pathology. So in some of entities, just by the serologic tests, the underlying pathology can be reached without the need to do renal biopsy. Okay, so the role of ultrasound is especially to tell us as when we are going to do biopsy, especially if it is shrunken kidney, the need to do biopsy is less, because in the case of shrunken kidney, the outcomes are usually fibrosis, scar, okay, sclerosis. So any etiology can give you sclerosis. So it's the end result for any of the pathologies being fibrosis, sclerosis. So then that will not may tell you much. But in some cases where genetic causes are anticipated, might be done for the rest of the families to counsel. Okay. To rule out obstructions and to see for cystis when you are going to do biopsy, are they amenable or not, will help you. So, and the increased echogenicity will not tell you the exact etiology. That's not be very much specific in the diagnosis. Okay, so there's a importance of ultrasound is to look at the cortical thickness. If they are thinned of cortex, then the likelihood of recoveries are gauged. So biopsy is a gold standard to diagnose glomerular disease. Okay, so in biopsy there are different panels. So we do light microscopy, immunofluorescence, and electron microscopy. Most of the patients might not require electron microscopy. AIM is usually required for patients with presenting nephrotic manifestation to differentiate in some of the etiologies like Marchand disease and FSGN. So, but immunofluorescence and light microscopy are very important. Okay, in settling up the diagnosis. Okay, so biopsy is the unless there is a contraindication, it's very important to do. Okay, but in some of pathology disease entities, you might treatment with short of biopsy. Okay, children presenting with a nephrotic syndrome, treatment trial can be done because minimal change is the most common cause. Okay, patient present the clinical history suggestive of post-streptococcal gene with high ASO titer, with low complement. Okay, having a prior sore throat or skin infection, likely post-streptococcal gene. So there is less appetite to do biopsy. But even then, in post-streptococcal gene, there are specific indications to do biopsy. Okay, so there are specific indications for to do biopsy. If the course is protracted, the persistent, low C3, and then to differentiate between some of the membranous membranoproliferative MPGN etiologies like C3J biopsy might be done. Okay, so the other is someone who having renal pulmonary manifestation with high anti-GBM titer, pulmonary hemorrhage, and the likelihood of GBM is quite clear, so might not need to do biopsy. Okay, someone who has features of vasculitis, okay, with uncapped serology positive, especially the C-ANCA type, which is more specific, then treatment might be started with short of biopsy. Okay, so in short of this, okay, like the membranous specific, this PLA2 are antibodies, okay? These are specific more for membranous nephropathy, okay? This can be membranous nephropathy can be diagnosed in short of doing a biopsy, okay? So biopsy is a gold standard, okay, because it helps in the diagnosis, in terms of telling the prognosis, but some of the disease entities, okay, treatment can be started using short of biopsy. So to revise again, 24-hour urine protein is very important. Usually we tend to collect a 24-hour urine protein to have a consistent measurement. So to start in the next day morning, starting from morning, okay, they should discard the first void of the early morning, and they should start collection 24-hour, and they should involve the day after, okay, so morning urine, so that will make a 24-hour. 24-hour protein might not be ideal usually for children, but this is a gold standard to measure 24-hour urine protein. Okay, this helps also in terms of monitoring treatment response. Okay, hematuria, as we said, defined is glomerular when it is accomplished by proteinuria or by looking at RBC cast. Okay, hematuria may not always help us in follow-up of treatment, but in some entities like IgA nephropathy and some form of vasculitis helps us in the follow-up of treatment. Okay, so when we go to the general overview of management of complications of glomerular disease, okay, so most important is to address proteinuria. Okay, so we need to target treatment that reduces proteinuria, ACs in the ARBs, okay, and to control the hypertension, okay, preferably with AC and ARBs. Sometimes it may be difficult to use AC or ARBs in the face of rapid rising creatinine. Okay, in this scenario, it's not preferable to use AC or ARBs because it will end up the treating physician that related with treatment that you have started or from the underlying pathology. But in someone who has stable creatinine with a proteinuria, a way forward is to start AC or ARBs to decrease the proteinuria. And hypertension is another target of a treatment. Hypertension, generally, the guidelines recommend to target less than 120, but as a common practice, and because there are no strong evidence as well, generally target between 120 to 130 is the recommended target blood pressure. So sodium restriction, moderate protein restriction. So this protein restriction might not work for our setup because most of our patients are behind protein. But we need again to tell that because they are losing their protein in the urine, they shouldn't try to replace by taking high protein. Okay, that misconception from misunderstanding the view from our patient side. So we need to tell that does not need a replacement, but they should not be much restricted again. Okay, physical exercise, okay, decreasing body weight, smoking cessation, reduction in alcohol consumption are very important part of general treatment of glomerular disease. Okay, so the other is those patients who have very low albumin, especially less than 2, may need, especially for those who have a nephrotic syndrome, unless they are contraindicated to start anticoagulation in setup where you INR coagulation profile can be monitored. Is ideally therapeutic dose of warfarin is indicated for at least 3 to 6 months, or where the underlying pathology is that's to mean the nephrotic syndrome is addressed. Okay, so when it is not possible to monitor the coagulation profile, might be difficult to give warfarin. So the other option is aspirin is also a good alternative. Okay, so in other patients where patients having low albumin less than 2.5, having additional indications like heart failure, bedridden, or other systemic manifestation, which with increased risk of thrombosis, anticoagulation should be started. Contraception is the other important point, because patient is getting pregnant while having an active disease, the outcome is very bad. Okay, pregnancy outcomes are very bad. Okay, they may end up in early pregnancy termination due to high uncontrolled blood pressure. Okay, and IUGR. Okay, and early neonatal deaths are also common. So it's not only complicated by progression in the renal failure, but also by the outcomes of a pregnancy. Early neonatal days, intrauterine days is also very high. So that's got maternal, fetal, and obstetric complications are very high. So patients should be counseled to avoid pregnancy during the active phases, okay, of treatment. The patients for lupus nephritis, okay, some of the treatment, not only for lupus, but the others also, the treatments are also teratogenic, so patients should be on contraceptive. Immunization should be given, especially well ahead of immunosuppressive therapy, okay? And as we said, some of the diseases like tuberculosis are high chance of flare, so latent treatment of LTBI is warranted. Okay, this is one of the group of patients whom now even our guidelines are considering to start treatment for prevention of latent TBI for someone who is on high dose of immunosuppressive therapy. Okay, so concomitantly, management of cardiovascular disease factors are very important. Okay, the patients usually have a dyslipidemia, very high lipid profile that should be addressed with statin, and lifestyle modification should be also addressed. Okay, supportive treatment with diuretics, okay, and sequential diuretic blockers and optimizations are also part of the treatment. Controlling hypertension, treatment of the dyslipidemia are also very important. Okay, and the other is the specific treatment. Okay, always before aggressive immunosuppressive therapy, we need to look up into infection screening, viral infections, hepatitis B, C, chance of this viral hepatitis being aggressive flares is very high, so we need to start either concomitantly, or we need to first address this disease, because they might be even the reasons. Okay, so immunosuppressive therapy before started for tuberculosis, viral hepatitis, and other parasitical etiologies like strongyloiditis should be addressed. Okay, strongyloiditis is also should not be forgotten. Okay, because the patient is having strongyloiditis, the chance of having hyperinfestation with strongyloiditis is quite high when they receive steroids. Okay, and glucocorticoids is the mainstay of treatment in any of the group. So even with a short course of treatment with immunosuppressive therapy, the chance of hyperinfestation are quite high. So we need also to be careful on these parasitic infections. So the other immunosuppressive therapy depends on the etiologies, and chemoprophylaxis like for PCP, cotrimoxazole. For those who have allergy for cotrimoxazole, considering dapsone is also an alternative. Okay, H2 blockers, PPI are also as a chemoprophylaxis. And don't forget also bone mineral disease when patient is receiving this high dose of immunosuppressive therapy for long-standing disease for duration. So this is to be addressed. So calcium supplementations, okay, calcium with vitamin D are also to be considered. Okay, so one of the presentation of patients with glomerular disease is body swelling. So diuretics is the mainstay of treatment. So patients may require high dose of diuretic to decongest because of their hypoalbuminemia also. Okay, we need to restrict their dietary intake and sequential blockage with because the chances of diuretic resistance is very high with thiazide diuretics. Okay, in combination with high dose diuretics, followed by, if they're not complicated by hyperkalemia, adding aldactone or potassium sparing drugs. Okay, if all are not working, and it's also good to consider astazolamide, because diuretics can result in diuretics-related metabolic alkalosis. So that to address astazolamide is also one of an important additional treatment that will enhance diuresis. Astazolamide alone is not a good diuretic agent, but when it is an add-on by sequential blockage, it will give a good diuresis effect. Okay, if all are not responding, albumin transfusion, especially for those patients who has very low albumin, less than 2, should be considered. And then finally, if they are not all responding, ultrafiltration might be a way forward in terms of managing the diuresis, okay, for the swelling. So ACO-RBS should be considered for someone who has stable renal function test. Okay, some steroid sensitive glomerular disease may not require ACO-RBS, like someone with minimal change disease. Okay, because they have a quite good response with steroids, they may not require initiation of ACO-RBS. Okay, but other with stable renal function test, it's important to address proteinuria with ACO-RBS, and minor increment in creatinine is expected. Okay, increment up to 30% is tolerated. So just by looking at these minor increments, this ACO-RBS should not be stopped unless there is quite a progressive increment in terms of their renal function test. Okay, so it's important to address. And the target blood pressure, as we said, if we're able to achieve 100 to 130, is quite reasonable. So the other is prophylaxis agents and vaccinations. Okay, PPI, SH2 blocker that we have discussed, and then patients with like lupus. Okay, ultraviolet protections using some protective factors like 50 plus. Okay, even from 30 plus is very important to prevent the flare of the drug. Okay, effective contraception and fertility protection, especially for those who receive immunosuppressive therapy like cyclophosphamide, high dose, young reproductive groups. Okay, so now setup using alternatives, especially in the reproductive age groups, is also recommended. So infection, to say a few points, because infections are quite high as we are living in the tropical area. So and strongyloids infections are quite high. So some studies from high school as a population-based studies showed, especially in adults have high carrier rate with a high good sensitive tests. Okay, the usual tests are not sensitive in picking strongyloids infections. Okay, so but population-based studies showed like 47% in one study as having an adult population. So we need to consider prophylaxis treatment for our patients who are going to receive immunosuppressive therapy, because the hyperinfection and the gram-negative sepsis due to the strongyloid related to the strongyloids result in a debilitating outcome. So it's an important. So even the recommendations from guidelines also in event that screening is unavailable or delayed in high-risk patients, some also advocate for empiric treatment with ivermectin. We don't have ivermectin routinely. It's just a programmatic drug. So in short of that, we need to consider second-line options like albendazole should be given while concomitantly when we use immunosuppressive therapy. Latent TBI infection is, as we said, our guidelines are also going to be, I hope, included sooner as part of treatment, in addition to the previous known patients with living retroviral infections. Okay, PCP, cotrimoxazole is important, but some patients are allergic for cotrimoxazole, so we need to consider alternatives like dapsone. So to say a few points about regarding specific etiologies, I will not spend a lot of time with specific etiologies. Okay, IgA nephropathy is quite the most common cause of glomerular disease worldwide. In our countries, we also see both primary IgA nephropathy and secondary IgA nephropathies, really following retroviral infections, other infections, okay, IgA nephropathy. So patients with usually present with hematuria, plus or minus proteinuria, a slow progressive courses. Okay, so the most important treatment in IgA nephropathy is optimization of blood pressure control, reduction of proteinuria by ACRRs. Okay, that's the most important. The other treatments are based on the prognostication and the degree of biopsy involvement based on the MESC score. So treatment might be given. Okay, sometimes IgA nephropathy may have a concomitant pictures with minimal change disease. Okay, IgA nephropathy may have a rapid RPGN clinical pictures where they might require specific treatments. Okay, so the most important is to control the proteinuria and the hypertension. Okay, IgA has a lot of secondary causes infections. Okay, like retroviral infections and also viral causes like hepatitis, cirrhosis. Okay, can be a cause for IgA nephropathy. So the most target is to optimize supportive care. So we need to focus on that. The additional treatments are quite not with not like significant and remarkable outcomes unless they are having a minimal change disease picture or a RPGN appearance. Okay, so the treatment is if they have not response with the supportive care, steroid or prednisolone for a 6 months course is one. They might even respond for that. Treatment may require either MMA4 or cyclophosphamide. Sometimes even with all this, they may have an aggressive nature. Okay. So we suggest patients to remain to have high risk progressive stage despite supportive care are considered for 6 months of steroid is an important treatment. Okay, this is so the other etiology of nephrotic clinical picture is membranous nephropathy. Membranous nephropathy is it's quite the most common cause in the western part of the world, but it's also it's one of the causes in our setup. Okay, there are primary membranous causes, okay, idiopathic membranous etiologies and secondary membranous. So secondary causes like lupus nephritis is one of the causes of secondary membranous nephropathy. Malignancies can have secondary membranous nephropathy. Drugs, toxins can have a secondary nephropathy. Okay, membranous nephropathy, IgG related, sarcoidosis and infections are also the cause of secondary nephropathy. So someone who has membranous nephropathy, especially in the absence of displar PLA2R antibodies, need to have an aggressive workup for a secondary etiology. Okay, secondary etiology as a cause for membranous nephropathy. Someone who has a FLAR antibody in the biopsy or a blood, okay, then that the chance of a primary membranous nephropathy is very high. So treatment is directed against PLA2R antibody titer. Okay, and then the risk is assessed either as a low risk or high risk. Someone who has having a high risk with a proteinuria of this is to categorize the risk group of membranous nephropathy. Someone who is having a high FLAR above 120, high proteinuria above 8 grams. This needs a group. This group of patients need a treatment. Okay, so the good thing about PLA2R antibody, they also help us in terms of follow-up of the treatment response. Okay, so the treatment membranous nephropathy. So the most important, again, optimization of supportive care with ACR, with starting treatment. And this group of patients are high risk for thrombosis. So anticoagulation is very important in this group of patients. So calcium urine inhibitors, alkaline agents are also treatment of options. Okay, and the other options now is rituximab. So rituximab can be given in a weekly courses for 1 month or 1 gram every 2 weeks. Okay, then that suffices as a treatment. That's and the new thing about membranous nephropathy is the tail-A2R antibodies, and rituximab being as an important part of the treatment in addition to the previous known alkylating agents in the same nights. So very high risk groups still. The old treatment cyclophosphamide is very high. As we said earlier, the risk classification is based on the GFR, proteinuria, the antibody titer, and the GFR. So these are part of stratification. So for those patients with a low risk, it's wait and see. And for the moderate risk, optimization of treatment with ACR, that's okay. But for high risk groups, rituximab is one of the treatment choice. For very high risks, cyclophosphamide alkylating agent is a treatment of choice. Okay. So for those who have no response, then one can be exchanged over the other. So someone who has been started with rituximab, no response, and then a trial of cyclophosphamide can be geared. Okay. So the other group of patients having nephrotic syndrome presentation is the minimal change disease and the FSGN. Sometimes they say it is a different kind of etiologies, or sometimes they say it is a spectrum of a single disease. Okay, so minimal changes disease is quite common in pediatrics age groups, but it's also seen in adults age group, in the younger age group, and in the elderly group. Okay, there are quite a number of secondary causes, drugs that cause minimal change disease. Okay, there are also triggering factors like allergic disease, allergic conditions for a minimal change disease. So the treatment of minimal changes, once the biopsy has proven, then steroid is a treatment. So the chance of relapse is very high. Okay, whenever there is a relapse, a short course steroid also will be one way of response. But whenever there is a frequent relapse and no response for a minimal change disease, then it's important to consider possibility of FSGN. Okay, so when we commit treatment, we need to give for adults a minimum of 16 weeks before embarking and saying there is no response. Okay, once we commit a treatment with a steroid for any of the pathologies, we need to give a reasonable doses for quite periods. Okay, especially when we start in short of biopsy. Generally, for a nephrotic presentation, it's not recommended to start treatment in short of biopsy unless we have true serologies and the clinical presentations like a minimal change disease presentation age groups. Okay, or a true serology from a PLAR antibody results indicating membranous nephropathy. Okay, otherwise, embarking on steroid alone syndrome with a steroid, and we need to monitor the 24-hour with responses for at least quite reasonable period, like up to 4 weeks. Okay, up to 4 weeks. So we need to wrap. What we see sometimes is considering with a nephrotic syndrome, steroids are being started, but rapidly tapered. Okay, we consider steroid responsive nephrotic syndrome, then the treatment should be given adequately with adequate dose, 1 milligram per kg, not half milligram per kg. Okay, then it should be given quite for a reasonable period, monitoring the side effects from a treatment, the Cushingoid complication, the Cushing manifestation like the hyperglycemia, the Cushingoid appearance, the hypertension, and we need to also closely monitor for the infection. So because in order to shift for a second line treatment, someone received a short course suboptimal dose, then that might not be wise decision. Okay, so ideally biopsy, but if you commit for steroid, high dose, quite reasonable period with a monitoring. Okay. Finally, whenever there is steroid resistance, okay, or not responsive, then we need to use alternative second line regimens. Okay. So minimal change disease in adult. So if there is no contraindications for steroid, go ahead steroids. For if there is a steroid, then the options are different options. Okay, so cyclophosphamide, CNI, okay, MMF with reduced dose of corticosteroids, like MMF with DEXA, are the options for treatment. Okay, sometimes you may use for those not responsive rituximab. Okay, rituximab as one of option of treatment, especially for those who has a previous theory of response for steroid. Rituximab can be also a salvage treatment. Okay. FSGs in adults is especially in our setup or in this black population is quite the commonest cause of nephrotic syndrome. Okay, so so patients may present with nephrotic picture. Okay, so those patients which usually called the primary FSGS type. Okay, they usually have nephrotic range proteinuria, low albumin, without edema. This is usually the primary FSGS. But FSGS is not only due to the primary etiologies. Okay, so patients may have a nephrotic range proteinuria, but not necessarily a nephrotic syndrome. It's to mean that their proteinuria is above 3.5 gram, but normal albumin, no edema, no dyslipidemia. Then nephrotic range proteinuria. In the absence of nephrotic syndrome, the secondary causes should be valid. Infectious etiologies, genetic causes, and other etiologies, the drugs should be considered. And optimization of supportive therapy is the main focus. Okay, the main focus of the secondary etiologies of FSGS like presentation. So we don't need to embark on steroid, especially when you don't have biopsy. Just patient having a nephrotic range proteinuria, but without a picture of normal albumin, no edema. So it might be due to a secondary cause. Okay. So what has been new regarding this KDIGO guidelines 2021 update with a member with a nephrotic presentations is one is the biopsy confirmed IgA nephropathy, the MEST score of the MEST-C score of MEST-C score of the biopsy classification of IgA nephropathy, treatment or supportive care, and for those who are not responsive for supportive care, treatment with steroid is the way forward. The most important biopsy the most important update is in membranous nephropathy. In membranous nephropathy, biopsy no longer might be required, especially for someone who has presentation of nephrotic syndrome with PLA2R antibody positive. Okay, and longitudinal monitoring of PLA2R antibody are also helpful in assessing treatment responses. This is the new update from previous guidelines as well. And rituximab is one of the part of the treatment in addition to the alkylating agent and the CNI. And what has been changed regarding minimal change disease in adults, there is no significant change from the previous guideline. And in about FSGS in adults, there are changes. So it's now categorized into a primary, a genetic, and undetermined etiology of FSGS. Okay, so FSGS can be primary etiology, secondary etiology, genetic causes, and undetermined. So after doing biopsy, this FSGS can be categorized into this category. So typical nephrotic presentation in the diffused podocyte effacement is a typical feature for a primary nephrotic primary FSGS presentations. Okay, and FSGS lesions with nephrotic syndrome likely is a primary, as we said, and treatment is recommended with immunosuppressive therapy. To see a few points about nephrotic manifestations, okay, post-streptococcal gene is the most the common etiology that we need to be discussed in our setup, because infection-related genes are quite common in our setup. Okay, so one of the etiologies is post-streptococcal glomerular nephritis, and even though most of patients present in the literature is described to have a subnephrotic proteinuria presentation, but we see quite a number of patients who clinical presentation looks like a post-streptococcal gene to have a nephrotic range proteinuria. Okay, that's probably needs it's my personal and colleague my view, okay, which needs further studies. But our patients usually have a nephrotic range proteinuria presentations. Okay, so post-streptococcal gene is diagnosed with a clinical typical pictures. Okay, very high SO titers, especially those from upper respiratory tract infections. Okay, in other setup, the full package of streptozyme tests should be done, but we have SO titer, and the other is complement. So they usually have a low complement dose 3 level with normal C4. Okay, so usually this low complement level will improve starting from 6 weeks, but usually it gets normalized after the 12th week. Okay, if after the 12th week persists to have low complement loss history, it's important to consider other etiologies of glomerular nephritis, like C3J. Okay, the culture might not be positive. Okay, always. So one of the infection-related gene is post-streptococcal gene. Okay, you predominantly activate the alternative complement pathway, but the other is infection-related gene is whenever they have inactive infections like endocarditis, osteomyelitis, and abscess, the cause might be ongoing infection and gene. So in these scenarios, it's very difficult to use immunosuppressive therapy. So you need to be careful because this ongoing infection might get flare and then may result in a debilitating outcomes. So the other etiology of with a nephrotic presentation is vasculitis. This is also another etiology which we tend to see quietly. So in this etiology, the patient may have a different kind of pictures. Okay, not only the rapid progressive gene, the RP gene clinical picture might not always be there, but the slow progressive course might be there. Okay, they may have extrarenal manifestations of vasculitis, recurrent upper respiratory tract infections, new-onset asthmas, okay, and skin manifestations. Okay, and patients may have a non-resolving kind of pneumonia. So this should be, we need to think of vasculitis in these scenarios. Okay, and then serology workups like Sianka, Pianka, ELISAs should be done, and with extrarenal manifestation having typical ELISA, especially the Sianka positive treatment can be decided even in short of biopsy. Okay, treatment is usually the induction is cyclophosphamide with glucocorticoid, especially for those very high aggressive natures with very high creatinine. The treatment, cyclophosphamide plus glucocorticoid, is still the mainstay of treatment. But for those who has less aggressive treatment, less aggressive disease, rituximab with glucocorticoid is one other scheme of treatment. Okay, so a maintenance treatment is preferred. Maintenance treatment is azathioprine in this scenario. Okay, so plasmapheresis is a controversial issue. So in some scenarios there might be helpful. Okay, so the other important change regarding vasculitis is rapid taper of the steroid. Okay, you need to rapidly taper the steroid. Okay, unless in most of the scenarios, unlike the previous day, patients whom were tend to be stayed on high dose steroid nowadays, the treatments are being on rapid course of tapering. Okay, good. So the other etiology that we encounter commonly is lupus nephritis. Okay, lupus nephritis present with a spectrum of manifestation from a subtle proteinuria to nephrotic range proteinuria with or without an active urine sediment or hematuria. Some of them patients may present with rapid progressive increment in creatinine. So especially in the face of rapid progressive RPGN pictures with a positive ANA titer and then PSGN titer, it's quite treatment can be considered. Okay, so unless otherwise, ideally the way forward is to do biopsy to classify type of disease. Okay, a type of disease. So in lupus nephritis at entry, biopsy may be required. Okay, usually is required. Okay, but rebiopsy might be also required when there is a change in clinical picture of the present patient or when you decide for treatment discontinuation. Okay, so lupus nephritis is one of the GN which we commonly encounter. So in addition to the immunosuppressive therapies, the antimalarial drug, which we usually use chloroquine, but hydroxychloroquine is the one option. Okay, so is very important part of the treatment in terms of reduction of flare of renal flare and also other systemic flares, and also is important. And it's also important to continue these antimalarial drugs during pregnancy. Okay, during pregnancy, it's very important drug in terms of controlling disease, in terms of immunomodulation of the disease. Okay, so it's quite, because most of the patients are in reproductive age group, it's important to counsel during not to get pregnant during pregnancy. Okay, it will be complicated. One, there is high chance of flare during pregnancy or immediate postpartum pregnancy. Okay, the other is treatment might be discontinued because of the pregnancy, because MMF is cyclophosphomides are teratogenic, and the steroids also will have an impact on the fetus. So it's quite difficult and important to counsel the patients to avoid pregnancy during active phase. And usually it's recommended to have after a disease well controlled. Okay, 3 months of MMF. Okay, so to avoid teratogenic effects from the MMF. Okay. So to say a few points regarding what's new, update from previous changes of 2021 guideline. So infection-related GN, there is no change. Okay, so patients with hepatitis, so hepatitis related glomerulinias and also MPGNs. Okay, that is one of the disease involvement. So immunosuppressive therapy might be required in patients with immunosuppressive therapy, might be like rituximab might be required in patients with Hep C related MPGNs. Okay, so the other important change is the classification. So MPGN, previously MPGN used to be classified into 3 categories, but now classification is quite different. Okay, so CIS related GN, immune related GN, and non-immune deposit GN. So MPGN pattern. So the CIS3, the complement related GN, the complement can be again classified into CIS3 and C4 GN. CIS3 GN again classified into CIS3 glomerulopathy and CIS3 dense deposit disease, and the immune mediated MPGN is classified into autoimmune disease, infection related, and monoclonal gammopathy, and the other is non-immune non-complement related MPGNs. So these are like KMS, okay, microangiopathies, okay. These are patterns which, so basically MPGN is a pattern of a disease. So among MPGN, so there are immunoglobulin related MPGN complement that we said C3 and C4 gene, and non-complement or immune associated MPGN patterns. Okay. The other new update is in terms of treatment with vasculitis, the rapid tapering of steroid. Okay, rapid tapering of steroid. Okay, so following the Plexivast trial, rapid tapering after 1 week, almost 50% reduction of the steroid. Okay, with rapid tapering, and plasma exchange should not delay time to a kidney failure, so alveolar hemorrhage. So this is the plasma exchange is not sounding as on the previous days. Okay, so the other is lupus nephritis. So lupus nephritis now class 5, especially following the 2024 guideline. So class 5 membranous nephropathy pattern. Okay, so especially for those with membranous pattern less than 1 gram of or less, or non-nephrotic range proteinuria. So not aggressive treatment is required. Okay, so less intense treatment with steroid. Okay, so but for the others, MMF is the other treatment. So and the other is volcosporin is a significantly altered or as a steroid sparing effect. Okay, so regarding anti-GBM, there is no much changes. Okay, so these are the changes regarding the guidelines. So this is what are the changes in terms of regarding the guideline. So the most important point is to focus the subtle manifestations, to look into the urine pathology, which is urine analysis in detail, and to go further workups following the urine analysis. This is what I have. Thank you.
All right. Thank you very much, Dr. Nebiyu. Let's proceed to answering some of the questions that we have from the chat box and the Q&A section. Let me share some of the questions. All right. So if Dr. Nebiyu, if you're listening to me, the first question reads: how is the availability of serologic titers for lupus, ANCA, or membranous nephropathy, and biopsy services?
Thank you. It's a nice question. So they are available, these titers. I know the limitation is that these are quite expensive tests, okay, especially the full package tests, okay, but these are available, both qualitative, quantitative tests, especially on a quantitative test, and the ANCA ELISA quantitative tests, the PLAR tests are available in town. They are usually sent to abroad, so they are available. And now it's not like as previously we get the results in reasonable period. Usually these titers are sent abroad, and usually they come in 10 days up to 15 days, and the tests outcomes they are reliable. Okay, most of them they are good, and whenever we encounter, usually we try to most of the professionals, my colleagues, they usually comment these laboratories whenever they see unusual test results. Okay, so but they are available. Biopsy service, yes, biopsy is available. The issues with the biopsy service is usually sent outside. Okay, but we also now get, as we said, renal pathology service here in Addis, so it's quite good pathology report. So we do a biopsy. So what is the problem is it's a little bit quite expensive for most of our patients. It's the only concern. Otherwise, biopsy service is available when it's sent abroad. Usually the turnaround time that it is usually it takes 3 weeks to 4 weeks, okay? But the reports are quite nice, okay? They're quite nice. So the BAP service is also available, and we are getting also the serology titers.
All right. Thank you, doctor. So the second question reads, how much beneficial is combination of ACE inhibitors and ARBs, and what are its adverse effects?
So the beneficial effect is ACE and ARBs combination is most of the guidelines they do not recommend. The most important reason is for hyperkalemia. Most important reason is hyperkalemia following majorly two main studies. The hyperkalemia risk is quite very high, and in our setup, especially, I don't recommend it because it's very difficult to monitor the potassium level as closely as we wish, and also we don't have those oral binding agents because these oral binding agents are quite expensive. So in some patient group, this especially in the young groups with proteinuria looks good, but the risk benefits, the risk outweighs the benefits. So it's not generally recommended to combine ACE and ARBs because of mainly the adverse effect hyperkalemia.
Okay, thank you. So the third question reads, is it possible to make a diagnosis of IgA nephropathy in our setup?
Yes, IgA nephropathy, we send, as I said, biopsies, after doing biopsy abroad. So we have the patients having a primary and secondary IgA nephropathy. Yes, we have patients with IgA nephropathy. So we have quite a number of patients, okay? But the biopsies are being done.
All right, okay. So why do we need to avoid dihydropyridine calcium channel blockers for patients with IgA nephropathy? And can we use amlodipine for blood pressure control?
So generally, this calcium channel blockers should be avoided because there is an increased risk of proteinuria. So that's why generally not to use this, okay? But it's preferable drug is ACE or ARBs in terms of control of controlling of blood pressure. But if you can't use this calcium channel blockers, if you can't use for ACE or ARBs due to a protein rapid increment in creatine or hyperkalemia, so controlling with the blood pressure with this calcium channel blocker is one way of treatment modality, because we don't have the other alternatives that help us this proteinuria like the verapamil and the diltiazem are not readily available. So calcium channel blockers controlling the blood pressure is very important, because poorly controlled blood pressure has also an important impact in terms of disease progression and proteinuria progression, as well as cardiovascular morbidity and mortality. But ideally, it's recommended to use ACE and ARBs or ARBs.
Okay, thank you very much. Fifth question reads, since RPD is the most common report from radiologists, how can we take as an input for approach of patients with glomerular disease?
So renal parenchymal disease or a medical kidney disease is a report that we get from radiologists. So this feature can be from different etiologies, be it from interstitial, from long-standing other etiologies. So it's not necessarily to be a glomerular. The most important thing that we need as a report is to see the size, okay, the size of the kidney, whether it is amenable for when you do a biopsy, or if it is shrunken. The most important thing, if it is a shrunken kidney, and it will tell you a chronic GN. So in this scenario, we will try to optimize mostly on the supportive care, focus on the supportive care than doing a biopsy and other additional treatment. So renal parenchymal disease will be helpful, especially taking the report including the size. So will be helpful. There is chances still, because not shrunken, there's a chance still for treatment with immunosuppressive therapy. Okay, so renal parenchymal disease will not be will not diagnose glomerular disease by the radiology. You cannot diagnose the glomerular disease just from the radio report. The report that we get from them is helpful for subsequent treatment decision.
Okay, thank you. So the sixth question reads, can we diagnose lupus nephritis without doing kidney biopsy?
Yes. So someone having ANA positive anti-DNA, high titer with low complementers, okay, active urine sediment with nephrotic range proteinuria, and this is either class 3, class 5. We may not say the specific class, that might be limitation, but it's we can say a likelihood of the lupus nephritis. Even a treatment can be decided by using this serology test results in short of biopsy. Yes, biopsy will be helpful, but for someone with having rapid creatinine increment with ANA titer positive anti-DNA, and then the chance of being lupus nephritis very high. Yes, we can start. We can diagnose.
All right, thank you, doctor. So the last question we have says, is there a possibility to discontinue anti-proteinuric agents after achieving trace proteinuria in a patient with glomerular disease of undetermined cause, especially considering our setup limitation?
So if the antiproteinuric agent is started with for someone with normal blood pressure, just for per se for proteinuria, to begin with, the patient might not have from the outset an indication to start proteinuria. But if it is started just for a proteinuria purpose, and the proteinuria has been improved persistently, normalized, then it's possible to discontinue. But mind you, antiproteinuric agent might be started for other many reasons. If once it was started for a blood pressure control, it's better to continue the antiproteinuric drug as antihypertensive drug, even though the proteinuria has been improved. Okay, so that might be a transient reason which the patient was started with antiproteinuric agent. So the proteinuria has disappeared. Yes, there is no benefit, then we can discontinue that.
Okay, sorry. So thank you very much, Dr. Nebiyu. On behalf of our entire Yetenaweg team, I want to extend our sincerest gratitude for delivering this very interesting session. I hope participants have gathered something important from your expertise as well as from this engaging delivery. And as a follow-up, we'll be sending a post-CME quiz link in the chat box. So I encourage all participants to take the quiz, and the certificates will be provided to those who have attended the session as well as gotten above a score of 50%. The quiz will be open for about 15 minutes only. And after that, we will go through the questions together with Dr. Nebiyu. So please make sure to finish quickly. And once again, thank you for your participation. All right, everyone, thank you very much for attempting the quiz. Since we don't have that much time, we will proceed to quickly answering the questions with Dr. Nebiyu. So let me just share the screen for the questions. Dr. Nebiyu, are you with me?
Yes.
All right. So the first question reads: a 45-year-old male patient presented with anasarca of approximately 1 year duration on HERAR 2013 with worsening in the preceding 1 month. Physical examination revealed anasarca with ascites, pleural effusion, and peripheral edema. Laboratory findings indicated normal CBC plus realbuminuria with a blunt sediment, creatinine level of 1.1 milligram per deciliter, serum albumin of 1.5 grams, and hyperlipidemia. Additionally, the 24-hour urinary protein was measured at 9 grams. Hepatitis B surface antigen, hepatitis C antibodies, HIV antibodies, rheumatoid factor, and ANA were all negative. What additional serology tests can be done to diagnose his condition in short of renal biopsy? So the choices were complement level must be done, PLA2R antibody with high titer can be enough, without renal biopsy, diagnosis cannot be reached, and without additional investigation, treatment trail can be started. So almost 61% or 50 responses were correct in answering B. So doctor, please proceed to explain the question.
So, as we discussed, renal biopsy is one of the gold standard in diagnosis of patients with nephrotic syndrome, but conditions like membranous nephropathy, where their PLAR PLA2 phospholipase A2 receptor antibodies are positive with high titer, it's likely a diagnosis of primary membranous nephropathy can be diagnosed. So this, you might not need to do biopsy. Without short of biopsy, treatment can be started by looking at the titer and the clinical condition. So clinical condition is categorized as mild, moderate, high risk, and very high risk. And the patient having very high proteinuria persistent for years. So this fulfills to high risk and very high risk group. So this warrants for treatment. So just by looking at the PLA2 antibody receptor, we can reach a diagnosis of primary nephropathy in patients who have a nephrotic presentation. So you don't need to look at the complement level, because the complement level usually be normal in patients with nephrotic presentations. There are some scenarios where secondary nephrotic presentation where low complements might be affected, but in terms of reaching the diagnosis, having a low complement or normally need to do biopsy. In short of biopsy, you can. So the question is, in short of biopsy, without biopsy cannot be reached. So yes, but in some scenarios like primary membranous can be reached without biopsy, and treatment can be started without them. So as much as possible in patients with nephrotic syndrome, because this only will have proteinuria, leg swelling. Sometimes they may have a terrible kind of body swelling, but most of the time their creatine GFR is preserved. Okay, most of them. So they will have a time. So most important thing is optimization of the diuresis, AC inhibitors, and counseling and planning for biopsy. There is no rush in terms of starting immunosuppressive therapy like the other conditions. And the responses for pre-insulinol or glucocorticosteroid patients with membranous nephropathy is less. So you need general reaction.
Okay, thank you very much, doctor. So the second question reads, a 64-year-old male with past medical history of hypertension, hyperlipidemia, and osteoarthritis, currently on metoprolol, simvastatin, and acetaminophen, presented with new onset lower extremity swelling, fatigue, and weight loss. Physical examination revealed a blood pressure of 122 by 74 millimeter mercury, heart rate of 82 beats per minute, and a grade 3 bilateral bleeding edema. Investigations revealed a creatinine of 1.1 milligram per deciliter, albumin of 2.1, total cholesterol of 314, and fasting blood sugar of 98 milligram per deciliter. Urine analysis revealed a class 4 protein with fat droplets observed on microscopy, and protein to creatinine ratio was 7.5. 24-hour urine protein revealed 5,068 milligrams from 2 liters of urine, and hemoglobin was 9.8 grams per deciliter, and stool occult was positive, and on left leg Doppler ultrasound, it showed a proximal femoral DVT. So what additional tests do you prioritize in the work of this patient? A says renal biopsy, B says workup for malignancy, including colonoscopy, C says SPEP with free light chain, and D says bone marrow aspiration. So proceed, Dr. Nebiyu, in answering the question.
So the patient has nephrotic presentation, and old age was a DVT and then occult positive. So nephrotic syndrome, always before doing a biopsy. Yes, biopsy is a gold standard, but we need to rule out secondary cause. Okay? So one of the manifestation of malignancies may be presenting as nephrotic syndrome, which usually present as membranous nephropathy. So the biopsy may say membranous nephropathy if you do biopsy, but nothing non-revealing, especially if it is negative for PLAR, and so the biopsy might not help you. Yeah, it's important to do, but you might not need to prioritize. So the question is not only doing investigation, but prioritizing. So it's always to prioritize a secondary cause etiology. If the occult is positive, the patient is having DVT and old age, so anemia, so likelihood of malignancy should be ruled out, especially colonic malignancies. Okay. The third alternative C is serum protein electrophoresis with free light chain. So myeloma kidney is a possible cause, but in this patient, there are not much specific features suggested for myeloma kidney disease. So in terms of prioritizing workup, so the fact that the stool occult is positive and then having a DVT with anemia, the patient's malignancy, especially bone marrow aspiration, the same as with free light. So always old age presenting as new onset edema, think of malignancies and rule out as ruling out with possible investigations should be also a priority in the workup of patients.
All right, thank you very much, doctor. So the third question says a 19-year-old female presented with body swelling, which started bilaterally from her lower extremities and flank pain of 2 months duration. She also reported decreased urine output and easy fatigability, for which she was admitted to a local hospital and given Lasix and prednisolone. The treatment showed no improvement, and she was referred to your hospital. Otherwise, there is no history of fever or urine color change. On physical examination, she looks chronically sick looking, and her blood pressure is 158/90. Her pulse rate is 102. Her respiratory rate is 19, and her temperature, she's febrile to touch. On investigation, the WBC was 8,900 cells per millimeter cube, with neutrophil 76% and lymphocytes 6%, and hemoglobin was 9.2 grams per deciliter. Creatinine was 2.1, which changed to 3.8, and 24-hour urinary protein showed 2,580 milligrams, and on urine analysis, protein was +4, and there was also +4 blood with many RBCs and many WBCs. Hepatitis B surface antigen, hepatitis C antibodies, VDRL, rheumatoid factor, and PICT were all negative, and qualitative ANA was positive, and C3 and C4 levels were normal. And additionally, abdominal ultrasound revealed a bilateral echogenic kidney, likely renal parenchymal disease with massive ascites. So what is the best way of management for this patient? Dr. Nebiyu, you have the floor.
Thank you. So this patient has, as we said, a nice positive active urine sediment. So even though the complement normal, so she's having subnephrotic range proteinuria. This patient is a patient who fulfill lupus nephritis. Okay, so ideally, yes, biopsy is needed, but as we see, the creatinine is trending very high rapidly. So waiting for a biopsy result, and even doing the biopsy might be at high risk because subsequently, as the creatinine very high, the risk of bleeding very high. So she's also having ascites, waiting for ascites to clear. Doing biopsy might be a challenge. So in this patient where NISP is trending higher up, prednisolone alone is not a way forward treatment. Steroid alone with a prednisolone is not enough. So this is a kind of patient who require aggressive treatment. Okay, even in short of biopsy, this is enough, as we said as we discussed when the questions arise. Can lupus nephritis be diagnosed by serology only? Yes. And this is a kind of scenarios where you can diagnose lupus, rapid rise in creatinine, and positive anti-acid, positive with high titers, and then some of the proteinuria. So this is the kind of patient who need aggressive treatments. Cyclophosphamide is prednisolone. For induction treatment is best way. It is MMF is prednisolone is an induction regimen. Rituximab alone is not for the time being from studies point. And as induction alone is not a treatment option. As a print alone is again not a treatment option. So cyclophosphamide with prednisolone or MMF with prednisolone is the induction treatment.
Okay, thank you, doctor. So the final question reads, a 52-year-old male from Asala presented with 1 week history of generalized body swelling associated with decreased urine output and cola-colored urine. He has no prior skin infection or upper respiratory tract infection. Upon presentation to nearby referral hospital, his renal function test trend showed creatinine that changed from 4 milligrams per deciliter to 5.4 milligrams per deciliter in 2 days stay. He was started on diuretics and referred to Glomerular Specialized Hospital for further evaluation and management. RFT at the Glomerular Specialized Hospital revealed creatinine of 10 milligram per DL with many RBCs per high power field and a protein of class 2. Serology for Hep B, Hep C, and RVI was negative, and ultrasound was showing echogenic normal-sized kidney. So how do we manage this patient, Dr. Nebiyu?
Thank you. This is the usual scenario that we see. Patients present with rapid increment in creatinine where we don't know their baseline, which the first done at the referral hospital may be very high, like this patient 4, 5, or might even like be 10, the initial presentation when they visit a hospital. So, and probably when they came from a country rural site to setup, creatinine being very high. We see like patients, one of the patients like creatinine of 19, okay? But the urine is active. When you ask the history, they were relatively okay. They have recent body swelling, okay, decreased urine output, cola-colored urine, no evidences for infection. So just X-ray and revealing blood cell cultures workup should be done, which again turned out to be negative. So waiting this patient, then because anuria, they are not responding for diuretics, patient usually get hyperkalemic, so they usually start on hemodialysis, okay? So is it either hemodialysis enough? Not, okay? This is a kind of patient whom hemodialysis is important. Ideally, while on dialysis, with optimization of the dialysis, doing biopsy, looking at the serology, and treatment should be started immediately, okay? So this is a kind of patient, if there is no infection or infection-related GN evidences, treatment with immunosuppressive therapy should be started immediately. Even for someone who's not having an active sepsis, even for infectious etiology, okay? Even for a post-ritual GN, presenting with dialysis requiring AKI, okay? Then there is a room to give immunosuppressive therapy. There is a room. So the only thing is to monitor the degree of immunosuppression so that not to over-immunosuppress the patient and to expose for infection, okay? Then once the patient is stabilized, then we do a biopsy, further workup, and decide on further therapies, like how shall we proceed on the immunosuppressive therapies and so on. Because time is very important. So after some period, if you don't treat aggressively, okay, then the course might be irreversible. Sometimes we see in a matter of days, things becoming unreversible, okay? So, you know, like AKI is usually reversible, but some forms of RPGNs will be irreversible even in a matter of days, okay? So it's my message is someone active picture of urine, protein, okay? Then serology is negative, no evidence for infections, normal kidney size, measured, not just a report, measured, okay? Even in the face of local sham hyperphosphatemia and raised PTH, there is a room to give immunosuppressive therapy with a close monitoring and further work. So I strongly suggest to consider this kind of treatments, okay? But further therapies might be required, further workup might be required with nephrologists, but in communication with nephrologists, because time is very crucial in this kind of scenarios, okay? With the communication, it's important to consider immunosuppressive therapy, okay? Starting hemodialysis, yes, is part of the care, but only supportive care with hemodialysis is not enough in such patients, okay? There are chances of recovery, okay? Start hemodialysis and refer for renal biopsy before starting treatment, okay? So ideally, if there is no infection, because biopsy is not something that you can get right away, and patients might not get done immediately because for biopsy need optimization. So in the meantime, starting treatment, if there is no evidence of infection, is a better option, okay? Starting hemodialysis and counseling for renal transplant, that's not choice to be decided, because some active diseases need to be quite quiescent for quite reasonable period, like more than 6 months before thinking a transplant, okay? So this is the common scenario that we encounter. So when you start steroid, as we said earlier, there is no infection, you need to be able to be aggressive. Like if you have a methylprednisolone like 250 milligram to up to 500 milligram, okay, for 3 days as a pulse dose, or in short, if you don't have such steroid, prednisolone 2 milligram per kg should be considered. Okay, then with communication with the nephrologist and referral for a better setup will be important, because that will help facilitate the referral and then the help in the recovery of the patient, for the recovery of the patient.
Okay. Thank you very much, Dr. Nebiyu. So to finalize the session, once again, thank you very much for sharing your time and expertise with our participants, doctor. And we look forward to future collaborations with you as well. And for participants, make sure to join our social media platforms. As we mentioned earlier, today's CME session PowerPoint will be posted on our Telegram channel, so you can have access to the PowerPoints as well. So with that, we would like to adjourn this session. Have a good night, everyone.
Thank you very much.